Eastern Sydney PHN's event for tonight, keeping you and your practice COVID safe while still seeing patients, especially at the moment. So first, I would like to welcome, we have Margaret Jennings, who we have had as a special guest. Margaret is a microbiologist, an expert in educating us in general practice, and also looks after many other health professionals and primary health. We have Dr. Brendan Goodyear, who's our General Manager, Primary Care Improvement, who I'm sure you've all met before, and also Jan Sadler, Manager of Practice Support and Development, looking after all of us on the COVID support line.
Well, look, just to highlight the importance of tonight's event, it's really important that we practice really good infection control within practices, given what's happening with COVID-19 in our community at the moment. It's also important to note, in terms of a broader background, that nationally there's something like a bit over 8.2 million vaccinations that have been delivered across Australia. Now that's good, but clearly we want to get better. And what's also really important is that of that 8.2 million vaccinations that have been delivered, it's primary care who have been responsible for delivering nearly half of that. But we also know that, as well as, of course, delivering vaccinations, general practices are also seeing people in their practice who are not well. They are providing ongoing continuous care for patients who need that. And of course, at the moment, certainly in Sydney, we've got the lockdown, and we're also encouraging people, if they've got a cough or a sniffle, to get COVID tested, to be really careful about their movements. General practice is in the forefront about managing COVID-19, and that's why we wanted Mark to come along to really give us some really practical advice on how to better manage our infection control within general practice. Margaret, can I hand over to you now?
Okay, thanks very much. Things are stressful. I'm from Melbourne, and my heart's sinking for you. However, there is so much you can do. There's heaps we can do, and there's really good news out there in terms of internationally. So let's not bellyache and say, I wish, I wish, I wish. There is just so much that we can do. Now I've got to try and get rid of some stuff here. There we go. So there were just really three arms to what I wanted to discuss. And the first is the fact that we know that this is airborne spread. So let's, jump up, and it's the same with influenza. We've just been a bit slow in microbiology land, but we've grasped it now. And I was listening to Raina McIntyre tonight on the health report. And, she used this term that I've been looking for. And this is her term, safe air, and we need to start demanding it. So safe air, the word I use is that imagine you've got COVID and you're talking, and so the large droplets that come out of your mouth, nose, etc., and they will be, spit and snot and water, etc. You can imagine the bigger drops fall pretty close, within a metre, and historically and classically we've taught that's where the greatest risk is, and it probably still is. But we've kind of put this wall down and said, right, influenza is spread close up, measles is spread far out. Well, we just need to forget about that. So all of those of you who learnt classical microbiology like I did, 2 generations ago, throw that out. Let's get real and just imagine unsafe air. So unsafe air is where I'm in a room, no ventilation. What I mean by ventilation is that the windows and doors are closed, no aircon, no heating, and I'm going to talk about the counterintuitive thing about that in a seckie. And the air's still, and I've got COVID, and I'm talking and chatting and laughing and singing, all the things that you're not allowed to do. And can you just picture this cloud of my tiny particles, 2 or 3, 4 metres out from me, hanging. Unsafe air. I really like that term that she used. It doesn't move. Then why don't we put another person in who's got COVID? You see? a really thick, dense cloud. The people who do all the testing for the P2 mask, they know all about this, but this was a world that I didn't know much about till about 18 months ago. Bring into that room somebody who's susceptible. Guess what they're doing? 1.5 metres, forget it. When you're talking about airborne transmission, 1.5 metres does not cut it. And we even know that being outside can be a bit dodgy at present. So let's make our air safer. And Raina made a really good point. She said, you know, we demand safe water. Well, let's demand safe air. And so what might that be if I now look at your clinic and you go, oh my God, what's she talking about? Is she talking about 4 changes of air per hour, which is what we demand of our hospitals? And can I say not all of them have achieved it? Can we achieve negative pressure? Well, you know, good luck. We can in some rooms, can't in other. So you say, I'm in general practice. What am I going to do? And so I go, well, why don't we start with the obvious? And I'm going to give you a list of about 10 things. Don't write them down because you need to remember them. If you write them down, there's nothing like having to remember stuff, you know. So I know you're all probably having dinner and you're kind of in that post, brandy or whatever, but here they are. If you've got windows and doors to outside, you open them. I mentioned air conditioning and heating. Now, this is going to be a little bit counterintuitive, but I want to put this to you. People go, oh, I don't want the air moving around because, oh my God, you know, I'll just send that virus right through the aircon. No, it actually splits up the airborne particles and dilutes them even more. Interesting. So don't panic about your aircon and your heating. So windows open, doors open if you've got them. And I know that there are rooms that people don't have windows in, and I kind of think, is this a chance for us to say, is my practice actually in the right place? Because you know what? We're never going to go back, most likely, to, what do you call it, life as normal? Some things are going to change forever. And I reckon the way we do air, make air safe, is going to be one of them. And so, yes, if you're in a shopping centre, ask, excuse me, how many air changes per hour? If they say 4, oh my God, fantastic. They'll say they don't know, most likely. Sorry about that. So, but you've got your windows and doors open if you've got them. If you haven't got them, well, this is a risk. And I've pointed out the air, the aerosols, the airborne part, and they can be for hours. And so I could just hear you saying, right, that's the end of the lease. I'm moving elsewhere. So, you know, and all of you remember the really old days of the old hospitals. You've seen it on the telly where they had the patients recovering in those louvered window places, fresh air, nothing like it. So anyway, we know that about 4 air changes per hour, 4 to 6, and some say even a little bit more. What if I can't get that? Well, what if I can't get that? I'll tell you one thing we're not going to be doing. We are not going to be seeing people with respiratory symptoms, obviously without masks, no way. But I'd be really, really concerned if people didn't have a bit of a plan before a patient came in with symptoms. Now, I know that not everybody who gets COVID has, everybody who's positive PCR has symptoms. We know that it's absolutely at least 20%. Never get them. Never get them. You can probably add another 20% who are, the pre-symptomatic phase, people are infectious, et cetera, et cetera. So probably about 40% of infections are, picked up by people who are picked up or transmitted, I should say, from people who appear to have no symptoms. So we know it's a hardcore group of about 20%. They're just the latest ONS figures from England, Office of National Statistics. So we've always known viruses always, you'll get a percentage, just never. Mumps, I think 33%, never show a symptom, asymptomatic. So the air, I've made you stress about that, but it's important. And how are you going to address it? The other thing we've always taught classically is time and distance. The closer the distance, the longer time. But I've thrown ventilation into that, and that's a really important third thing. So let's look at these first two. And even before these first two, who's coming into my practice? The one thing that I'm really keen for is that general practice continues to practice, and it's actually important that when people are unwell that they are seen. But I need to keep it as safe as possible for you guys. So, and I'm not going to bring immunisation into this part because we're nowhere near herd immunity. So that's not, that's not a part of the equation and won't be for a few months yet. But this is not about just throwing everything down and saying, oh, well, that's it, I can't do anything. We can do heaps. So when you arrive at work or when you wake up in the morning, please don't come to work if you've got the slightest tickle. And I have to tell you, I had my second COVID test on Friday, negative, happy to report. But it was at, am I imagining this? Surely I couldn't have a slight sore throat. This is very normal. So you will go through that point, and then the next day I thought, Margaret, I'm going to go off and have it done. They're so gorgeous at the testing station. And there was a queue of us. And I'm in the northeast fringe of Melbourne, where, they're in a bit of la-la land here. They didn't sort of get really touched by the big outbreak. But we did have 13 deaths in our LGA, and people kind of have forgotten, honestly. So go and get that test. And in fact, I had a question from one of the Sydney PHNs, or somebody typed in, be careful what you type in, or I think it might have even been verbal. So is Margaret Jennings saying that even if I've got the slightest tickle or runny nose, I should get a test? Yes, I said that. Please. You guys have got amazing numbers, and we hit the 50s as well. I think you hit the 60,000. Fantastic, because every time you get a test, you add to those numbers. When they say that there are 35 cases, or 33, just trying to think, I think it's 35, and you are able to link all except 2, and by tonight you're probably able to link the other 2. That's what happens. People get a bit, oh my God, they don't know where it's coming from. But usually by the end of that day, they've worked that out. So testing is only as good as the people who come forward to do it. There's probably an extra layer of testing in Sydney at present, which are people who are having the regular testing, the surveillance testing, if you've been to a place, even if you're not symptomatic, and that would be the case for a lot of the testing. But it doesn't explain the fantastic coming forward of the public. I mean, this is something that should really make our hearts sing, that people will come forward voluntarily. And I saw them in the queue on Friday. There were the mums with the 15-year-old here on the back seat, looking very reluctant, but obviously had the sore throat. So before you come to work, this is where your infection prevention control starts. Should I just, what was I doing last night? Singing, talking, eating too much, whatever. No, I've got a bit of a tickle. You know what? I shouldn't be at work. It's as simple as that. And I tell you what, they'll all love you to bits at work, because the last thing anybody wants to hear at work is somebody coughing, somebody sneezing, somebody clearing their throat. No, off to get a test. Anybody in your household, this is how hard I am. Anybody in your household, you tell them. You guys, anybody, and the 15-year-old in the cave, you tell me if you've got a sore throat, because I'm taking you down to the testing station. I wouldn't come to work if I had somebody in my household with symptoms. Take them down and get tested. All right. Now, my test, was negative. You get a text at 6 o'clock in the morning next day, which good turnaround. But when somebody is symptomatic, oh, I haven't got COVID, and they then still go out. So please don't come to work, even if it's not COVID. We're not interested. And it's a shame they don't do a panel all the time. It'd be nice to know if it's an RSV, adeno, or rhino, or flu, or something like that. But we haven't got that luxury all the time. Some of them do the panel of all the other respiratory viruses, but most don't. So that's actually where your infection prevention control starts. So you jump in the car, you jump on the train, whatever, come to work, and you start. What do? Do you get your thermometer out? Well, I have to tell you, only about 45% of people get a fever. And by the way, with Delta strain, further down the list for those who are immunised, So the top presentation for those who are immunised, partially or fully, you can still get symptoms, that. It tends to be more the runny nose, throat, headache, and maybe a bit of a cough. So there's been a bit of an alteration there if you've had some immunity, some form of immunisation, or one or two. So you're going to really have a mixed bag. But I kind of think if all you're relying on is the thermometer, not great. So this now applies to your patients. And yes, we want you to come, but we're going to do it a bit differently. This is what you're saying to them. Some of you might have the capacity to see patients out in the car, and some of you won't. It can be a real mix and match through the day, and it's going to really depend on your situation. But I will not be having somebody sitting in my waiting room. In fact, I don't even think we're using waiting rooms at present. Basically, all people do is they're the next person who goes to see the doctor. We don't use our waiting rooms down here where I am. No way. So a receptionist just says, I'll call you when the doctor's ready. Do you want the doctor to come outside to your car? Do you want to see the doctor in the little tent, next to the clinic? So you can do all sorts of stuff like that. We've got nurses dressing wounds in people's cars. It can be done. The pandemic says find a creative, I'll put the word in creative, alternative to providing your healthcare. And I don't mean necessarily telehealth all the time. Sure, you can do some telehealth, but that patient you want to see, get them to come in, and maybe they don't come in if they're symptomatic. And don't chase them away if they're symptomatic. They might need to go to hospital. So this, I think, is about medicine probably at its best. And it's about really kind of tick, 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 could this be that patient? Could this be that patient? And I've got to keep my staff safe and the other patients safe. So I would not tolerate a person who's respiratory symptomatic, even with a mask on, in my clinic. Now, that's me. And of course, what happens? Right in front of you, the patient turns up with or without a mask and they're coughing. That's the reality of life. But being able to say to the people in your colleagues, this is what we do here to keep ourselves and our patients safe. We check each other, we check our patients before they come in, and we are going to see our patients, but whether we see them outside or we see them inside, if we see them inside, I've got to tell you, it's trickier. But it can also depend on how much virus is circulating in your community. Now, I noticed today, and these are the numbers I look at, the covidlive.com app on my phone continually, and the numbers I look at, people go, out of 33 out of 35, it's okay, they're in isolation. And then you hear the bad news. Well, some of them were wandering, and they didn't have dementia, but they're wandering. We all know about that, and that's why we had the army come in last year and check that people knock on your door, you should be home, you're not isolating, you're not quarantining. So that's about keeping in touch with your positive patients, calling them, and do they need anything? Have they been contacted by the contact tracers to see if they need stuff? We don't want people going out for any reason. This is a much more infectious strain, 100% on the original wild Wuhan, and 60-70% on top of the UK or Alpha strain, the Delta strain. So not to be mucked around with, and it just loves your throat. It's looking for it and it's finding it. So your numbers in the 30s, even though you say all except 2 were linked, I still shake a bit about those 33 because I need to know where the hell they are, if they're doing the right thing. But people may need some support, and people can get really strung out. They don't always feel bad about maybe they've passed it on to somebody else. Some of them do. So the numbers that I look at, that's just getting to be, it's just harder to keep control of things. And I think Wednesday is going to be your day whether things are going to go that way or that way. And I think by the following Wednesday, middle of July, you'll know which way it's going to go. Okay, I'll just say that, having been down there. But the genomics are good, 75% of all positives we do genomics on. So going back to your clinic, you've said, no, can't do anything about ventilation, but I want you to think about it because it's about the concentration of breath, if you like, in the air. So I did mention about distancing and almost forget your 1.5 metres, but do it because it's actually better than not doing it. So this is about this risk reduction. If people go, but I can only have 3 people in the waiting room. I said, don't have anybody in the waiting room. Call them in so that they go straight through to the doctor. Now, the poor old doctor, the doctor ends up with, or the nurse who's doing the dressing, ends up with the person, like that, and thinking, what have I got to do? I haven't got a window either. So here are some of the things that I've seen that I can relay to you of stuff that we did last year in Melbourne. Apart from tents, there are tents, you can do that, open-sided tents, and you can at least get more air movement because it's open-sided. But one clinic, I'll never forget it, they were all as happy as Larry, and they decided they were not going to use their consulting rooms to see patients in. The doctors, there were 8 doctors, and they said, right, this is what we're going to do. We're going to use our own consulting rooms for our telehealth. Fabulous, we don't have to wear masks because this is stressful. Stressful enough for the admin staff too, wearing them all day, even though they've got the sneeze shields, still need to wear masks. So the doctor said, what we're going to do is we can create 3 cubicles in our treatment room, and our treatment room has an external door. Now, this was this practice, doesn't have to be your practice. But you see what they did? They were then able to lower the risk overall because the patients would come in through the treatment room door, be seen in the cubicle, and for a private conversation, the doctor and the patient walked back to the car. Now, that was them, they're on ground level, and they had a car park. And that may not be your situation, but I just need you to think harder about how can I make this as safe? And I'll tell you what the end game is. What say you did nothing? And you get a tap on the shoulder from the contact tracers, and they say, look, 2 days ago or this morning or whatever, you had somebody in your clinic for something or other, unrelated even, and they've tested positive. Well, then you're a tier 1 exposure site. I think you guys use the same tiering thing that we do. And that means that you've had a positive case in there. So imagine if you'd had a positive case, but you saw all symptomatic people outside, and that you automatically all wore masks outside as well as inside. I tell you what, you would not have to close down. And I'm saying this a little bit out of school, but compare that. You're less likely to have to close down. You're less likely to stop work. You're less likely to pay for a $6,500 deep clean, okay, versus we do nothing. And we have to close down and fortnight, and we have to go and call up all of our patients and tell them and get them tested. So I kind of want you to see that as the comparison. When I do stuff to reduce risk, it usually means I don't have to go to the extraordinary lengths at the end if I do have somebody. Now, you might want to play the roulette a bit and say, oh, what are the chances that we get a positive in here? This is not the game that anybody's playing right now. We're in the middle of a global pandemic. It's worse this year than last year. It is worse. I've just been listening to a guy speaking from Ireland, and the UK is going like that. Hospitalisations, mercifully, are not huge, but they are there in the population who didn't get vaccinated, okay? So there you are. What can you do? Oh, you can use alcohol properly, not the way I see it being used. So just put that it's hadn't worn jewellery for over a year. So it's get a good duck pond in there, fingernails in, spread it all over your hands so it's nice and glistening wet, and now rub it. I don't want to see any of that, and I don't want to see one hand all dry. You need this to be still wet at 15 seconds, just going sticky by about 20. This virus has an envelope, a little fatty envelope, and the alcohol disrupts the envelope. And guess what's on the envelope? Those spike proteins. So it'll stop the virus from grabbing onto your next door, neighbour's throat. So use of alcohol. I want to talk about the 2 different masks that we use. And I have to be fairly careful about this, but wearing a mask is better than not wearing a mask. Only wear a proper mask. Don't bring anything in from home that you've made. This is not this era that we're in. And please don't let any patients in without wearing a mask. So I've got 3 layers. If you've not seen this little demo before, always wear colour to the outside. The softer one on the inside goes against your face. And I'm just trying to find that middle layer. Feels like skin. Okay, so these are all like a blown polypropylene, I think. So the big bits sort of hit here, but also these are surgical masks actually developed to stop bugs from the surgeon going onto the patient. And what you want is for them to fit nicely at the side and for there to be a proper nose bridge. So we've all seen the tracheotomy people, haven't we, lately? Bit of that going around Sydney. What about the mouth breathers? So the correct way to wear the mask is about a third of the way down the nose, make the bridge. And for those of you who wear glasses, they need not fog up if you put them on properly. So getting this tight is what's important. Pretty good. Now, nice and flat. Do not twist at the side because you now introduce a pocket and the air will just follow least resistance. I want to breathe through this, but you can see it's not perfect, but it's not bad. To take it off, there's only one way and only one place. Away and down, 2 hands, and into the bin. Not on the coffee table, not in your pocket, okay, in the bin, which leads me to how often, and I know all the practice managers will hate me forever saying this, but think mental health. I have read some ridiculous heroics. Oh, we just wear the mask all day. Well, who's drinking? Who's going to the toilet? Who's having some lunch? Please don't do that. So if I've got any managers watching, please keep an eye on the staff and tell them to get up. It's time to change your mask. Use it as an excuse. These don't work when they're wet. 2 hours. Okay, I don't mind if it's 3, but you know what I'm talking about. I'm talking about 2 good breaks. Even if one's a 5-minute break and the other's a 30-minute break. But people need to get these off. Go to the loo, have something to drink, walk around outside, just sit in their car where you don't have to wear a mask if you can. Listen to your music, talk to your mate on the phone. So that's that. Now, we used to sort of go by this thing about this is for when it's droplet spread, and this is for when these are the P2s, respirator mask. This is for when it is airborne, and you go, oh God, what's coming next? Well, I'll tell you what's coming next. I'm going to show you how to put this on and how to fit check it, not fit test. Fit test is where you go off to a machine, a person attached to a machine who does all sorts of fancy tests on this to see if there's any leakage. The test I'm going to show you today is the one that you also use every time you put this on, every time. So I can show you how to get a decent fit, that's for sure. And again, a fit check is better than the surgical, but I'm actually wanting you not to rely on this because it's where the air is not safe and I've got a suspect patient. That's where this comes into its own. So if we can actually stop the need for this, I'll be really happy. But you see where we really need them. So we need them in the COVID ward, we need them in ED, when we're just persons unknown arriving. When you go down to the car to see somebody who's got respiratory symptoms and you're going to have to stick your head in that car, that's where you might use this. So I'm going to show you how to put it on. Obviously, you do you'll need do your hands first. You'll need one of these and a pair of gloves. I'm not going to panic about the apron or about the gown, all right? But there is an affinity for the eye, the conjunctiva with this virus, and also people coughing at you. The person you're going down to see in the car may not have it. So these, again, I've seen heroics that you can wear these for hours and hours and hours. Well, good luck. But it's unnecessary. But I am going to show you how to put it on. So there are 2 straps there, and I'd like to think that at least one person in every clinic can use a P2. So you'll feel the nose bridge, you'll feel that it's a lot thicker. And some of the way this works, obviously I'm going to breathe through it, good seal, and there's some electrostatic charging of the layers. So I've got these 2. There are different ways to put on, but basically you put your beak in and one, I've got all clips in my hair for some reason, but one on the crown and one below the ears, all right? Always remember that. So about a third of the way down the nose. Obviously make sure nothing is in the way. If you've got long hair, you might want to wear a cap. So about here, I now fold it, mould it, and you'll find that it's a lot easier to mould this. No hair stuck. Now I hold this into a yawn and press it a bit more. Now I do some heavy breathing. And I should not feel any hot air coming out here, and I see it collapsing. That's not bad. Okay, that's not bad. Of course, gold standard is to go off and get a fit test. But remember, I don't even want you to be having to use these, because I want you to be able to have a risk-reducing strategy when you see your patients who are symptomatic. So to take this off, it's bring up these two over and down and out. Now in the hospital, when you're in the COVID ward, we wear this for repeated patients as long as it doesn't get splashed. It's called extended use. Okay, so when we're going patient to patient in the COVID ward, always do your hands after you've taken a mask off or handled it. Now, what other risk reduction? I've shown you how to use the mask properly. So if you haven't been using it properly, do it properly. If you haven't been doing your hands properly, do it properly. What about contactless payment? I don't think I've seen cash for about 16 months. I don't think I know what it looks like. I don't even want to touch it. And, you know, we talk about going back to how things were normal. I don't think people are going to go back to cash. Good. And what else can we do? Sneeze shields. Yes, you're wiping over of your high-touch surfaces twice a day. So what can you use? So you can use your good old ViroClean. Note, I haven't got a spray. You just press the lid onto there, wipe over the surfaces, the high-touch surfaces. So that would be, what is it that we all touch and share touch, and we wipe it over at lunchtime. And, you know, with a nice big wipe like this, you can probably do about 8 surfaces as you fold each one over. Don't spray. I'm not using sprays in healthcare. If you're really rich and you've got a wad of your disinfectant wipes, then put your gloves on, and you can probably get about 4 surfaces with that as well. Leave it wet and make sure the surface actually looks clean before you apply this. If the surface has actually got visible handprints, you'd actually want to clean it first. Then you can apply this, but leave it wet. We know that about a minute wet will bring about, say, a 4 log reduction. You know, what's that, about 10,000? So a reduction there of about 10,000. So that's what you want to achieve. But everybody can do the high-touch surfaces within their own, you know, what they can see. So you would do it at lunchtime and then again at home time, all right? But leave it wet. Again, the cleaner goes a bit, oh, what do you mean leave it wet? You know, it leaves a streak. We don't care. We're very happy. But it needs to be wet, and you cannot apply those disinfectants to a dirty surface. You've got to clean the surface first if it looks dirty, and then apply your disinfectant. Most of our disinfectants are actually detergents. So the ViroClean is actually a detergent, and the Pinoclean, the quaternary ammonium compound, which is effective at 0.4%, that's also a detergent. So you can actually use the one wipe to clean and the next wipe to sit on to disinfect. So really get into that. People ask about chairs. Well, if you have any with handles, you're in trouble because you're going to have people touch them. I know at one of the vaccine hubs they actually leave all the wipes there, and people actually wipe the chair as they get up. For a chair that's just like a shell shape with no arm on it, I couldn't even get it, and it's fixed. I couldn't even get excited about wiping it down. Sorry, but if it's one that people move around and they touch the back, then you know you'd wipe it. But like, always go for what is the least thing I need to do. And your waiting room, by not having people in your waiting room, except to maybe go through to the doctor, means that you're reducing risk to your receptionists. Now, speaking of receptionists, why would you have 2 receptionists on the one bench? Well, you wouldn't. And I can tell you that I had a clinic and both receptionists got it. This is in Melbourne. And I go, why have you got 2 receptionists there? Oh, we tried to keep our distance. Well, you know, you can't. They both got it. Well, oh no, one of us is on the phone taking the calls and the other's seeing the. Well, the one who's taking the calls can be in another room. Make life safer. So lots of alcohol, masks changing, sneeze shield, but why have people close together? So there are some of the tips. I think that's probably about 10. And so I'm sure you can run off to work tomorrow. They'll probably sack you on the spot and say, you know, are you in la la land? But these are the real things that we can do. Now, you may not be able to achieve all of those, and ventilation might be the one you're stuck on, but it is important. But then say, how much can I just reduce people staying in the same place for more than a few minutes? And, you know, this fleeting contact, I think, has got a lot of people quite concerned, and also just some recent evidence that even outside spread. So that whole thing about safe air really comes into play. Now, I was going to ask Bertha, could you pop up that little vaccination table I've got? Because I think this is really good. This is, I copied it from one of Raina McIntyre's talks, which is just generally about immunisation. Okay, are we able to make that a teensy bit bigger there? Only for my eyesight. Okay, and then drop it a bit. So this is, I'm doing my e-newsletter, and I just sort of prepared it today. But what I want you to look at is, this is how Raina's done it. So this is about, if your vaccine was so good, you can see 95% down to 50%, how much of the population would you need to vaccinate for herd immunity? And herd immunity is a concept that we only use around vaccination. You can't get herd immunity through natural infection. Otherwise, why did we have measles pop up every 2 years? So can I also say that the immunity conferred by immunisation is superior to natural infection? Just in case you've got to remind people in your sphere, I won't give them the name, some names that I use, but people who think it's better to have the infection. Oh my God. So you can see that if you have a 95% effective vaccine, you would need to cover 63% of the population. And it's very hard to get a 95% effective vaccine. Measles is probably our top example. Can I say that the two main vaccines used in Australia are very, very good. I'm kind of a little bit sick of hearing people put down the old AZ. And my hunch, I'll take a bet on it, is that we're going to get a superior immunity perhaps with the AZ. However, follow the guidelines, all right? And be prepared to change with the guidelines. You know, we're able to use evidence here in Australia. Some countries have not been able to use good evidence because they've had to jump in and do stuff. So we're in a slight sweet spot, but we're all kind of on a knife edge at the same time. So then you come down to, say, a 90% effective vaccine, and you'd have to have 66% of your population immunised. Okay, so you can see the way it goes. And you can see really you probably don't want to go below 70%. Now, the World Health does approve a vaccine that is a 51%. I think that's Sinovac or Sinopharm. But, and you'd have to have, you know, more than 100% of people. Well, that's not achievable. But you can see what we look at. We're looking for that 70 to 95. So don't get hung up on, oh, this vaccine's only 88% and this one's 95. Can you see, in terms of population coverage, there's only about a 3% difference in how many you'd need to get covered. So don't look up Google, for heaven's sakes. Stay with the what we know. So you really do want over 70%, and that's the way we're pivoted in Australia. All right, so I just wanted to put that up. Just before I ask Bertha to take that off, can you see that if you have a look at the three types of vaccination you can do, mass, targeted and ring, we're almost doing all of that. So we started off with mass, then we realised it was quarantine and health, not then, and we also realised it was quarantine and healthcare staff. So you would have seen we more or less had two programs together, where kind of anybody over 60, if you like, you can maybe say that's a bit of targeted, but we did a bit of that. And then you would have just heard today with the nursing home that they are immunising staff during the outbreak. It's the least preferred, but it's more or less what we call a post-exposure prophylaxis. And you might get a bit of a bounce from that, where people start to make some, start to have an immune response before the the virus takes hold. So we'll see. So you can actually see there, we're doing a little bit of all three in a way. The perfect time to immunise is in the inter-pandemic period, which would have been last October. But the vaccines weren't ready. They weren't ready to be, they'd just been tried. So it would have been impossible really for people to start in October. I think the earliest ones were November, December. So that's the spot we are now. So what I'm going to do is, I had millions and millions of things to chat about, but I'm actually going to stop because I think you've got some questions, and I think we can take that down. So what do you think, Fleur? Is it time for some questions, or Brendan?
Yeah, we've got some questions here for you, Mark, if that's all right.
Yeah, now remember, I'm not a clinical person, so don't ask me anything about drugs or whatever, okay?
I wouldn't. Okay, so first of all, there's practices, some of these are kind of linked, and these are linked to the ventilation. So there are practices that we have in shopping centres. So they don't have an outside facility for patients. So your tips for them. And there's another one here about ventilation. If you don't have windows and you've got aircon blowing, what's the difference between hot and cold air?
Right. Don't panic about hot or cold air, okay? I mean, if it's really hot, it'll probably inactivate the virus, but I won't go down that path. Let's go back to the shopping centre. So I'm visiting this particular clinic and they say to me, look, Marg, we're in a shopping centre, what can we do? And I go, you've got why have you got 20 chairs in this waiting room? Well, this is where people wait. And I go, well, what's wrong with them waiting in the corridor, in the shopping alley? Is that what you call it? There you go. I'd be putting some chairs outside. Mm-hmm. Okay, absolutely.
You'd probably find that it would be a work safe issue for the shopping centre would not allow chairs outside of the door of the facility.
Well, right now, the shopping centres are probably at higher risk of transmission than the clinic itself. And this is what I mean. I can tell you in Melbourne, a number of clinics have really rethought why we position here. Go to the shopping centre management, number one, tomorrow, and say, can you tell me how many air changes I've got in this thing? And you know what? If they can't answer, you've got to have a strategy. Now, remember, I've said I'm really not wanting to see symptomatic patients in the thing, but I need to see them. So that practice is going to have to work out. And I mean, this is about how you run your practice. I mean, I had a practice call last week and say, oh, we do swabs on people who are about to depart for overseas. So, well, what if one of them is positive? And I go, well, you then become a tier 1 site and you have to, oh, but we can't afford to close. And I go, well, why don't you do the swabbing outside? Oh, sorry, I'll get really grumpy. So that was the first one, but they've got 2 things to do. And you might be surprised that the shopping centre doesn't mind people sitting outside. I mean, do you know what? Of course they can sit outside. The clinic doesn't have to provide the chairs. They can go and have a coffee and you can buzz them when you're ready. Who would know? So there you go. Just got to think a bit more creatively. What was the second question there, Fleur? Was it...
It was about ventilation and hot air and cold air. And then can I just add to that one, tack onto it? What about air purifiers?
Well, can I just say one thing? And this is today. Somebody said, oh, we've got a viral filter on something. Well, I nearly collapsed because viruses are unfilterable. You cannot filter a virus. They're that tiny. That's their definition. Any of you who did microbiology, definition is it's a non-filterable particle. So what we aim to do with this is just block out 95% of particles less than, I think it's 0.3 mu. And the viruses are not always free. They're often attached to bits of spit and snot. So I think what the person's saying, if I've got an air purifier, and believe you me, they are using air purifiers in some of the hospitals. They even used them last year to try and just make the level of aerosols lower in the air. So it's not a silly question at all. But don't talk about filtering the air of virus, because it's actually not possible.
Okay.
But there's somebody thinking, there's a practice thinking that I don't have windows, I don't have doors, how can I make it a little bit safer? So it's not about what I think, it's just about what steps can we take. But I think, honestly, to stack up your waiting room with people, even 1.5 metres apart, is not great. There'll be somebody in there who's symptomatic and hasn't fessed up that they are, because some of the patients think that if they say that they've got some symptoms, that you don't want to see them. And we really do want to see them, because we might have to do an oxygen thingy and send them off to hospital if they're not fantastic. And remember, if they're partially immunised, they're not always going to be turning up with breathlessness and stuff like that.
Yeah. And so we've still got the hot air and
the hot and
cold air.
Look,
does it make any difference?
I'm not an engineering expert, but what I can tell you is that dispersal through heating and cooling can actually dilute that cloud of unsafe air. So that's about as far as I'm prepared professionally.
Is a fan the same? Does a fan do the same as aircon blowing?
For ages we said no fans, but they've just sort of gone a bit lame on that. Fans aren't great for lots of reasons. I think
a roof fan would be different than just like an stand-up fan that would blow something directly.
I wouldn't deliberately put a fan on in my deliberately. I'd be looking at strategies to first of all find out about the air changes. Much better to have your windows and doors open than use a fan. But if you're in a building, that other people operate, it's got a manager, I'd be right there tomorrow saying, can you tell me how many air changes? And can I just say, the owners of these buildings and shopping centres, they don't know. Well, I know what's going to happen, but they don't know what they're in for. They are going to have to start putting this in, because this outbreak at shopping centres and stuff like that, this has got a lot of people in, my end of the profession really concerned about what we're going to have more pandemics. They're going into a third wave in England right now. But we're going to have more of this, and we need to address this sort of stuff. Now, we need to make these demands on those shopping centres. That's what we need to be doing. Yeah. So, no, I can't answer specifically about hot or cold air, but I think you see the principle of dispersing the cloud, because you actually need to get sick, you actually need to take in an infectious dose. So by dispersing the cloud, I'm not going to get as many viruses gripping onto my throat and making headway.
So I think we've pretty much covered a lot of the ventilation and air and disbursement. The common one we're now getting is, and so if we could have your opinion as a microbiologist, there's the question of, I'm fully vaccinated, I'm half vaccinated, or the whole practice is vaccinated. What are the chances that we will get COVID from a patient? What are the stats on that?
Okay, yeah, so those figures have also just become available again through UK studies. Well, usually it starts off, I'm vaccinated, and yes, you can still get it because no vaccine's 100%. And remember, the vaccine does not work as well in people who have comorbidities and in deprived areas. Okay, that's also come through in Tim Spector's, the Zoe study that's shown there. So people with comorbidities, they're just not going to make beautiful T cell response and beautiful B cell response. And a lot of us live with those people. So that's why, we, the healthy ones, do get sort of done. Now, just going back to your question, the person who has been immunised, yes, the virus can start to grow. But what happens is your immune system goes, hang on, seen you before, and starts to make a fairly immediate response. I mean, good circulating antibody levels within 24, 48 hours of that exposure after you've been immunised and you're exposed to the virus. But what's happened is the virus has begun to replicate. So you haven't got a wall around you that says, I'm immune. The virus has got to come in and start. And then your body gets, hang on, you're not coming in, boom, 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 and neutralises it, but it's begun to grow, which means that, yes, you can be infectious to others, but not as. So this is all about levels. So the risk is much reduced getting COVID from somebody who's been immunised but who has symptoms. okay, and they can just begin to get the start of symptoms. Some of them don't get any symptoms, but yep, it's been shown that the virus can begin to replicate, but it's much lower, much lower. So that's why we have immunisation. That's why it works. So there was another part to that question, which is, oh, why do I still have to use my whatevers? Still wear a mask? Absolutely. And remember, it may not have worked in you or worked as well. It's only really when we've got 70%, 80% coverage.
So if you're immunised with the 2 jabs and you get the virus, but you've got no symptoms anywhere, anything else, you can pass that on to someone else.
Yeah, potential, but it's really much lower risk.
Yes.
And of course, the more people who are immunised, who am I going to pass it on to? Yeah. Nobody.
So if all my colleagues, my team at work in the practice are vaccinated and somebody gets it outside the practice or even inside the practice, we're still all we've reduced dramatically the likelihood that we'll pass it on or we'll get really sick.
Yeah, and who are you going to pay? You're not going to get really sick. We know that the levels for both vaccines, being hospitalised, it's 90. Both of them are in the low 90s for you not going to hospital once you've been fully immunised. It's this partial immunisation that's just not as great. But we'll get there. We'll get there. And of course, that's what everybody wants. We want to be able to open up, and we can't do that at present. It's important to know that we want to open up. I think everybody does, and I don't think people want to live like we are, but I'm also saying I don't think we'll be living like we did 18 months ago, that we'll always be on the lookout for this and changes to this, this virus. Yeah. But certainly, and look, with the vaccine passports, for example, for the UK, it's actually got to be manufactured in the UK for you to automatically get that passport. So ours is manufactured here in Australia, and it's got to be approved. So you can't just sort of say, oh, well, that person's been immunised by whatever, a vaccine that may not be commonly used, that we don't know much about. It's going to have to be an approved vaccine for people to come in or leave. And there's got to be work done worldwide about what vaccines are acceptable, et cetera, et cetera. But, it was put to me that 30% of patients attending a clinic are vulnerable. That means, that they won't have a great immune response. And so, working in healthcare, that sort of, is crystal clear that I have an even higher responsibility as a healthcare worker to protect my my patients, because even though they may be fully immunised, I've got my transplants, I've got my leukemics, people on methotrexate, et cetera, who've really got not a fantastic, bounce from their immune response. And just lastly, on the immune response, look, I think it'll be shown how important the T cell response is. Everybody goes on about antibodies, which is B cell, but the T cell response is really, which is cell mediated immunity, is really important for this virus. And you kind of can measure it, but we don't offer it. It's not offered in the labs. So don't sort of get hung up about the antibodies. And I know that the AstraZeneca, the levels are still going up at 8-9 weeks when they're kind of stopping some of the studies. And I think it probably might be giving you a superior longer-term immunity, the AZ, but that's an opinion.
Just mindful of our time. Yep. And there's something that I know that us on the practice support and coronavirus team would love you to cover is the cleaning schedule, about having a cleaning schedule that if you clean all the touch points every hour on the hour, and what the doctor's role and everybody else's role, and especially to assist contact tracers.
Right. I saw that. I think we almost mixed up those 2 points, Fleur, but never mind. Yes. So the first thing is, with the contact tracers, what I was actually getting at is that if you are able to say to your contact tracer who says, hey, you had a case, if you're able to say, we don't see symptomatic patients inside, you see the contact tracer won't know that. All they know is the person said, I went to see Dr. So-and-so. Okay, so you're able to say this is our schedule. We don't see symptomatic patients inside, or you do. We don't see them face to face, or we do, or we didn't see that person, we saw them in the car park. So what I'm saying is, if you're the contact tracer and you're about to tell this clinic, oh, you guys it's a tier 1 exposure site, you've had close contact sustained, and you go, no, but we don't use our waiting room. Fantastic, right? So it's looking like maybe I don't have to close down. And then you go, oh, by the way, the doctor went out to see the patient. They're in their car. This is looking really good. So this really assists, not so much the contact tracers, but you will then liaise with the health department. And you can say, do we really need to do the stock standard, close down, testing, contact on our patients, et cetera, and they will say to you, yes or no, or just some. I mean, this is a huge relief to practices, but a lot of practices go, I can't do any of those things. We're really busy, and I go, you know what? And one day you might just have to stop for 2 weeks, and that can just kill everything. So preventatives, people often don't see the value in the preventative. You guys do your hands and you go, I don't know what I'm doing this for. I know why you're doing it, because I can just see if you get any of that virus on your hands, and you do your hands when your hands go to your mouth. And can I say that's one of the benefits of wearing a mask? Stops that. That I know that you possibly protected yourself. So until we get, 70-80% of our community protected, these are the things that we're going to do. And some of them we'll probably keep doing to protect the people who are really vulnerable. So I was just going to leave that there in terms of the contact tracing, but with the cleaning, again, what do we do here? And not every hour. I'm happy with twice a day. So think about lunchtime, think about home time. I've got 2 minutes. Give me 20 surfaces to do. Buttons, doorknobs, Medicare casing. You can even do that after every patient, whatever, although the patient's doing their hands. The pump, it's got a filthy big knob of gel. Not very attractive. Is everybody using the hand cream? All right, just do this in the middle of my cleaning, but I can't tell you how important it is to be using a compatible barrier cream, all right? So that's all the high-touch cleaning. That's the way to get your mind around it. I'm going to actually write down the surfaces. I mean, it feels mindless. Dr. so-and-so is going to, and nurse so-and-so, they're going to, sister so-and-so, they're going to be wiping over their devices, their oximeters, their stethoscopes, do you have the plastic blood pressure cuffs? Please get the plastic cuffs. The tourniquets, well, a lot of people are using disposable tourniquets. So think about how we can actually just have more and more wipeable stuff, scales, all of that gets wiped down. So the doctors and nurses have got that to do as it is. The receptionists are thinking about what is it that people touch as they come in. And I'm going to wipe that over at lunchtime. I'm going to wipe it over if I see fingerprints, and I'm going to wipe it over at home time. I would allocate every single person in the place to do 2 minutes at lunchtime, 2 minutes at home time. You can get those high-touch surfaces done, and that's what people are doing. Thank God they've all got those on. So everybody's got beautiful nails in Melbourne all winter. Okay, nobody was biting their nails, and I'm sure you'll be the same. So having it written down, actually writing it down, you feel a fool. Oh, the doorknob, the light switch, and start with the thing that is touched, even though it's high touch. Yeah, that means frequently touched. But do a light switch, because you probably only use that once a day. And then write down to something that people touch all the time. Of course, there's a lot to be said for self-opening doors. And when we talk about going back to so-called normal life, I think that's another thing that you'll see, not just improved ventilation, but less touching of door handles, more self-opening, more elbows, all that kind of thing. Okay.
There's another one here, why we don't use spray disinfectants, and I think that's purely for the sending everything around the room.
Oh, it's for splashback.
Yeah, splashback.
Splashback to you, and inhalation of chemical. Yeah, we just don't use sprays in healthcare.
And the other question we had was about, yes, it's great that if every reception practice has sneeze guards, that's pretty much the normal these days. But we don't see that it's important for health professionals to be in their treatment room with a patient to have the sneeze guard, because
that's because you've got to get up. That's because you've got to get it close. So this is always about what can I do? What are the things I can do when I don't need to be close to the patient? I step back, I go outside and have a chat, a privacy chat with them, back to the car. Whatever is possible. But what you say to yourself is, what are the risk reduction things that I'm using? Is it enough that the patient and I have a mask on? No, you can do a bit better, stand apart. So it's not about this is perfect. You know, being perfect is like in the desert 2 kilometres apart. Well, you know, that's zero risk. But how can I keep reducing it? And it's sometimes hard for people to talk in this space. I'm familiar with this space of risk reduction. Here's a 20% risk, here's a 40% risk. Whereas a lot of you don't work in that sort of realm. We want 100% guarantee, and that's not the real world. So we know that one person wearing a mask, I think, is 40%, 2 people wearing a mask, 80%. Now I do distancing, and that can make it 90%. And then I add ventilation, and you see, so as many of those levers that you can operate up, hopefully, not down, as many of those that you can operate will keep reducing risk. And there are people who can actually assess that risk very finely. But if you just say, what's the point? We don't even do our hands properly. And if we remember to wear a mask, it lasts all day. I think we can really move on from that. So I'd like to know, what are the 3 things that practices that I'm speaking to tonight, what are the 3 things we can do tomorrow that makes a difference? And I can tell you, everybody really needs to be doing symptom checking in their household and themselves before they come to work. Check each other, do a bit of a buddy check, and you just thank your lucky stars, you know, that you treated it seriously.
The other thing, just to remind everybody, is that QR codes have now become mandatory for all organisations and businesses. And yes, that includes general practices. You should have already been contacted by the Department of Health. New South Wales services have been contacting via email. So it is important that every patient and staff member is QR coding. And yes, staff need to QR code in. Now, what was explained to us early this morning was that when everybody's using their QR code that is given by the Department of Health, when a case is notified through their pathology, you will then receive a text message, there goes my dog, within approximately 2 hours. Okay, so it's a lot quicker. You won't be seeing that you're on the list. Okay, so that's really important that everybody's using the QR code. Yep. The other thing that is coming up that we get asked a lot, because practices get asked this a lot, is how long do I need to isolate for if I'm a close contact, or if I'm went there or not? What happens is the contact tracers will advise everyone individually.
Yes, and so what the contact, I did the course through Johns Hopkins. It's just excellent. And so I speak to somebody who is a close contact. The first thing I do, obviously, introduce myself, etc., check that I'm talking to that person, that they're safe to talk. And it's, have you got any symptoms? You know, I'm talking to somebody who's a contact, and they might say no. And so I will say, look, you know, you're asked to quarantine is actually the correct term, not isolate. Isolate is when you've actually got the infection, and quarantine is when you may get it. But people tend to just use the word isolate. I did hear Kerry Chant use it correctly today. And so they will say to you, no symptoms. Now, you know, your contact was 2 days ago, and that's why it might vary. Now, remember, are you doing contacts of contacts? Because we were doing those as well, and then they number in the thousands, and then you can release like 2,000 people on day 14 because, you know, they didn't get anything. Sometimes you can release people on 4 days if they were a contact of a contact, and that contact's turned out, you know, to be negative. I don't want to complicate it any more than it is, but when it's a case, it's when did the symptoms first start? Yesterday. So we know that the 2 days before that, they were infectious, and it's about who they were with in those 2 days. And then we go back 2 weeks. Where could you have got it from? Because we know it can be 14 days. In the extreme, in a couple of cases, 1%, I think, or less, it can be a bit more than 14 days. but they're not really shedding much at that point. And then, so there's upstream and downstream. You would have heard of upstream contacts or downstream contact tracing and upstream. Upstream is chasing back up there and tying up the loose ends. That's what they seek to do in contact tracing. Where could this person have got it? Have we opened a branch, a line here that we didn't know about? And that has happened in Sydney and Melbourne. In fact, we found a family of Delta embedded in our Alpha outbreak just recently. And just because they turned up for testing, thank God. But it was actually, one lot had come from quarantine and can't remember where and the other, the poor bloke who flew back from Adelaide and actually got it leaving quarantine. Do you like that? South Australia did apologise to us for our last outbreak. Very nice of them. So with the contact tracing, I did actually do something on it in my last newsletter, and I used Scott Morrison as the example of somebody who may have had contact with a case, because he was travelling. And so it was quite a real one. And I did that in my last newsletter. It's on my website. And the person who could be an actual case, I used Norman Swan. Hope he doesn't mind. But he lives in Sydney, and it was realistic. But I actually just went through the questions that I would ask him. So, if you kind of want a fairly simplified version of contact tracing, which is pretty amazing. And look, sometimes they've got to go back to people 3 and 4 times. People get a bit, fed up with it and a bit picked on, but we're desperate to find out. And, it comes down to their bank records. It comes down to their shopping dockets, their phones. It's quite...
Yeah, in depth.
Well, some would say it's intrusive. It's extremely intrusive, but also the information is only used to find out contact. It's not to report them to the tax for having 6 jobs, not paying any tax. It is just to find out where they've been. Now, what I've noticed too is that your outbreak has also drifted over to the left-hand side of Sydney, a bit to the west. And I'll tell you why, because it happened with us too. It started off in the wealthier suburbs, then all of a sudden it wasn't. And this is because people are, work in security, and they will go to work when they should be in quarantine because they basically don't get paid. And in a place like India, it's much worse. You don't eat if you don't go out to work. Okay, so
Okay.
Yeah, any other questions there?
There's a couple more, but we really need to wrap it up.
Yeah.
And I'd like to thank you, Marg, because we did organise this quite quickly and urgently. So
Thank you.
A reminder from your new staff, need to complete your onboarding training and your infection control training and your hand hygiene training. Also, Brendan, a reminder that if you've got any questions about COVID and the rollout, we didn't cover them tonight because we covered them last week, and we'll be putting Central Eastern Sydney PHN, we have a YouTube channel where all our webinars go on. So this webinar will be placed on that shortly. And we've got last week's COVID update on that YouTube channel as well. And what I just had one that clicked up and Sarah is reminding me is about people get stuck with babies and sick children that are snotty, and as on reception, triaging them and, mum's fine, but the baby's not, and letting them in. It seems like a bit of a fine line to cross.
I think you can, well, what we know about kids is they're getting it from adults. They're not really passing it back so much. And also remember, kids have snotty noses for weeks and weeks, and their shocking coughs can be asthma. So the kids thing I'd play down a bit. You want to see kids, and especially if they've got a fever, you don't want the sun set until you don't want the sun to set without having seen a kid, with a fever and stuff like that. But I don't know, maybe it's all that grot in their throat that just the virus goes, oh my God, I don't like this, I'm out of here. But my hunch is that their infectivity period is really short. Because they've got so many goodies going on in there, and we just can't work that out. But what we know is most likely next outbreak, I don't think we'll close the schools down once we've got more immunity, and I just don't think we'll be doing that because we're just not finding huge huge onward transmission. I know you've got a school there with 4 cases, but I think we're going to be taking a more measured approach to that, you know, Australia-wide with the next outbreak. And there will be another outbreak, everybody. You can bank on it every 3 weeks. Quarantine is a very human endeavour, okay? It's a very human endeavour.
Okay, thanks very much, Marg, and I'd like to thank you on behalf of Central Eastern Sydney PHN for coming on at such short notice to give us a bit of support with our infection